So welcome everyone and welcome to Eye Care and You webinar 28, all about low vision. We'll be hearing about what low vision services are, how to access low vision, and what is basically low vision clinics and what can you expect from an assessment. And today's guest speaker is the wonderful Louise Gao, and she is the lead in eye health and low vision, and she works at the RNIB. Louise, welcome, and please do introduce yourself properly.
Thank you so much. Yes, it was particularly nice to say for you to say wonderful. So yeah, I'll be appreciative of that for a while. um, so I'm an optometrist by profession, and I've worked for RNIB for just over 15 years now, running the low vision service there, and more recently, I've been writing the low vision services framework, good practice framework with Preeti Singla. So you might have seen that um, published from RNIB quite recently. I also provide low vision services at St Thomas's Hospital in London, and I work for Eligibility, which is the charity for people with learning disability and sight loss. I work in their children's clinic actually, so completely different. So I'm going to be talking about low vision. Bhavini very politely said, "You're only going to talk for 35 minutes, aren't you, Louise?" Because she's seen me talk before, and I can talk about this forever. So I've tried to get the key points, and there'll be plenty of time to ask questions at the end. So I'm just going to try and share my screen. And I've got a little PowerPoint, but don't worry, I am going to talk through every single slide so that there's nothing that you'll miss from the slides. I'm going to talk you through everything. So we've already done the first slide because that's just saying my name. So first of all, I thought we'd start with a definition of low vision because low vision is a bit confusing and there's lots of terms like sight impairment, sight loss, um, visual impairment, and low vision is just one of these funny phrases that floats around. And I think a lot of people are a bit confused as to what it actually is. So the official definition is an impairment of visual function that impacts a person's quality of life. This may be permanently reduced vision that is not fully correctable through surgery, pharmaceuticals, spectacles, or contact lenses, or it may be temporarily reduced due to uncorrected refractive error or while waiting for surgery. So I'm just going to take all the jargon out of that for you now and say basically low vision is where someone's vision has dropped below the average level of vision. It's causing them problems with day-to-day life, day-to-day activities, and we can't fully correct it with glasses or medication or surgery. And you can come under the low vision category if you're temporarily visually impaired as a result of, say, something like waiting for cataract surgery. So it doesn't have to be a permanent loss of vision, but most people that fall into the low vision category, we would say it's usually a permanent drop in vision compared to average. So it's really everyone who is of below the driving standard in terms of their visual uh, the level of vision, through to people who have count fingers, hand movements level of vision. So what's a low vision service? So again, lovely definition coming up here. A multidisciplinary service designed to identify and support the health and social care needs of people with vision impairment. This includes an assessment with a low vision practitioner, provision of low vision aids, training in their use, and direct working with or established referral pathways to other key services. So again, I'm just going to translate all of that. Basically, it's a service that includes lots of different professionals. So it might be orthoptists, optometrists, ophthalmology, GP surgeries, rehabilitation workers, so vision rehab specialists, um, lots of different professions, all that are there to support someone who has low vision to make the most of their vision, and to find ways around the challenges that their vision creates. So, who benefits from having a low vision assessment? It's people who have difficulties with activities of daily life due to their vision. So, if your vision is causing you difficulties doing your day-to-day chores, your job, the things that you love to do, then a low vision assessment may help. But it's also people who have a visual impairment and have some usable vision. So if your level of vision is below count fingers, hand movements, light perception, and if you have no light perception, then uh, the low vision assessment isn't really for you. But a vision rehabilitation specialist appointment is essential, and that will give you a lot of support, and obviously support from the ECLOs, and lots of other support services are all very, very important. If you're struggling to get other support, then you can always talk to the low vision clinic and they can link you with the ECLO or suitable support in your area. Um, what happens in the low vision service? So, what we do is we spend a lot of time just discussing with the patient the impact that their vision has on day to day life. So, what is it that the person is having difficulty with because of their vision? And that part of the assessment can be 20 minutes or so. And when I'm teaching the students, I tend to call that section of it the nosy Parker section. I don't know if you've heard that phrase before, but basically it feels a little bit intrusive because you're asking things like, how do you manage your finances? How do you manage your day-to-day chores and activities, your personal care, and those sorts of things? But it's important to ask those questions because those are the things that vision impairment can really cause you difficulties with, and there's lots of ways to overcome those challenges. um, so once you've had that conversation, you and your practitioner will work out what are the biggest concerns for you, and we call these targets. So it might be reading the letters that come through the door, it might be reading your medicine packets, it might be uh, managing glare. Perhaps what's happening is you're struggling with sunlight so much that you're finding it difficult to go out and about. So the practitioner and you will make a decision as to what's the most important thing. What you might find, however, is that practitioner will do a sort of a little mini risk assessment. So there might be things that don't worry you very much, but the practitioner will want to make a target because it might put you at risk of your health deteriorating. So, for instance, if you're not able to read medicine packets or manage your tablets, they might say, "Well, that ought to be a target because you could get unwell if you make a mistake with your tablets." And then what we do next is we measure your vision. So we'll use a letter chart, a contrast chart, and usually a visual field test. And I'm going to talk you through those in a little bit. So I'm just going to gloss over that for a moment. But we measure the vision. So by the good bit of your vision. So what's usable with your vision, and that way we know how we can make the most of that vision for you. So the practitioner will work out your best vision and how you can make the most of that vision. So that is using lots of different techniques. Um, we have a phrase that we use: bigger, brighter, bolder, audio tactile. So these are the strategies that we use. So once we know what we need to try and help you with, what level of vision you have, then we will consider which of those strategies we use. And usually we'll use a mixture of all of those. So, low vision services, you might have thought was a service where you go in and they give you a magnifier. And that's true, but we do a lot more than just, or should be doing a lot more than just giving you a magnifier. So I'm going to go through those strategies bit by bit in a moment. But first, I'm going to just go back to the tests. So I said about the letter chart and the contrast chart and the visual field. So the letter chart is the standard letter chart that you would expect in an optician. So black on white letters, otherwise known as high contrast letters. And we use a special chart in low vision called a logmar chart. And a logmar chart has 5 letters on each row, and they gradually get smaller towards the bottom of the chart. And the reason that we use a logmar chart is that it's a much more accurate way of measuring vision than the old-fashioned charts in the opticians. And it's really important if your vision isn't as good as it used to be, or if you're born with reduced vision, then actually using a Snellen chart, which is the sort of the traditional optical chart, means that you can't measure it any closer than the 6 meters that the old-fashioned charts were designed for. So these logmar charts we can bring much closer to you, and then we can really much more accurately chart what vision you have. If you use the old-fashioned charts, what happens is you go from 660 vision, which is the top letter of a standard letter chart, and then the optician would have to measure your vision as count fingers. And actually, there's lots of people that are a long way, within that, that you just don't get that measure of vision if you don't have a logmar chart. So your level of vision is sort of not measured properly if you haven't got a logmar chart. But it's essentially the same thing. It's high contrast black on white letters. Because our world isn't black and white, a high contrast letter chart sometimes doesn't really tell us the whole story about your vision. So I like to measure something called contrast chart with a contrast chart. So the contrast chart is sets of 3 letters, and every set of letters gradually fades out. So you start with black on white in the top left of the chart, and then it's gradually grayer and then grayer and then grayer and grayer, and then towards the very chart it goes white pretty much. Now, the importance of this chart is that we can see the quality of your vision. So if you imagine a light switch, a white light switch against a white wall, then you're much less likely to see that if you have poor contrast than if it's got say a purple band around it that highlights the edge of the light switch. So it's if you just measure someone on a high contrast standard letter chart, then you may well miss the fact that they're going to trip on steps and stairs and things that are not black on white or edged with bright yellow and that sort of thing. And I would say that, every nearly every clinic I'll see someone who sees reasonably well on a letter chart, but then I put them on the contrast chart and they do really poorly, and that's why they're struggling out and about. The other thing is that on a contrast chart, it shows up those people that really struggle with glare. So if you've got a hazy gel inside the eye, or if your cornea is hazy, which is the front layer of the eye, or if you've got cataracts, then that creates scattered light when you go outside, and that's what makes it feel dazzly and bright, and why things sometimes look less clear when you go outside in the sunshine than when you're in lower light levels or even light levels. And a contrast chart tends to pick that up better than a black and white standard letter chart. So there's lots of reasons why a contrast sensitivity chart is a useful test to do. Not every low vision clinic uses them, and I think that's a bit of a shame. But it's difficult to get some of the equipment in some of the clinics the way the funding is for these services. Um, but I wouldn't be without mine. It just gives that extra dimension, so I can really understand what someone is able to see. And then there's a visual field test. So visual field tells me what you can see to the side. You can have a really good result again on a high contrast letter chart, and you could actually do really, really well on a contrast sensitivity chart. But if you've got poor peripheral vision, that wouldn't show up on those charts so obviously. So, for instance, if you've got retinitis pigmentosa or advanced glaucoma, then you may well have lost side vision, and that will mean that like going out and about can be much more difficult than perhaps vision just on the letter chart would show. So you might see almost to the bottom of a letter chart. If you don't measure someone's visual field, then you may not realize exactly the level of difficulty they might be having. So those are the main tests that we use. Now, when you get these slides, you'll see that I've got the picture of a long distance chart, a contrast chart, and a visual field machine. Of course, we also use a reading card as well, because it's really important to see how well you do close up as well as in the far distance. But the principle is the same as just a standard letter chart. They're black on white letters. So if you think about a glossy magazine that's lots of different colours and a slightly shiny surface, you may well not see that as well as you do a letter chart reading card in in the low vision clinic. And we do take that into consideration. We know that when we're testing you with a reading chart in the low vision clinic, we know that that's the very best you can do. But if I gave you the same size print in a glossy magazine, you're probably not going to see it as easily. A glossy magazine, you get lots of reflected light, and the contrast is really poor. So I'm just going to go through those strategies very quickly with you, so you get to know what sort of things that we might be able to suggest and offer. So remember, I said bigger, brighter, bolder, audio, tactile. So I'm starting with bigger because that's the most common thing that we do in a low vision clinic is we try and make things bigger. Because if you magnify something, then usually it's easier to see. It's not always the case, but usually it's easier to see. So magnifiers are the most obvious tool that we might hand out to patients. So these are optical lenses. They're just like your spectacle lenses, only much stronger, and they're held in a frame, and usually they've got a little light attached to them. Not all of them do, because some people find the bright light actually makes it worse. So you might hear them referred to as illuminated hand magnifiers, simple hand magnifiers, stand magnifiers, illuminated stand magnifiers. There's quite a big range of them, and the power of them starts from something like 6 diopters right through to around about 56 diopters. And depending on the level of vision that you have on the high contrast letter chart, that's how we would work out how strong the magnifier needs to be in theory to enable you to read smaller print or to see in the distance better. So most magnifiers are free on the NHS. All low vision services should be providing something for you free on the NHS. They may, I know some clinics will cap it at 1 magnifier per patient. Most clinics will give at least 2 magnifiers if you have the need for that. They're prescribed for your level of vision and the task you need them to help you with. So they'll be one of the targets that we'd set at the beginning. So, say one of the targets was to read your medicine packets, we would be looking at how much magnification you need to read the small print. And then we'd try you with that magnifier and see if it works. It's really important that you have training. So, training should be given in how to use and maintain the magnifier. Um, it's not intuitive using a magnifier. No one is born knowing how to use a magnifier, and they're quite tricky. The stronger the magnifier, the shorter the working distance, and the sort of smaller the area that you can magnify. So it's quite tedious. It's quite frustrating. Certainly initially, it can be very frustrating, but you need the practitioner to show you the best way to use it and how to get the best out of the magnifier. For some people with arthritis and problems with their wrists and that sort of thing, they might not magnifiers might not be for them at all because they can't hold them, and they can't keep them steady enough. If you've got a tremor, for instance, that might be a reason that a magnifier isn't going to work for you. But it's something we try pretty much with every patient. Um, some people will prefer to use their smartphone nowadays, because the smartphone, so an optical magnifier has got one power, maybe two. Sometimes it'll have a little additional part on the lens which is a little bit stronger, but most magnifiers have just one power on them. On your smartphone, there's a magnifier app or a built-in magnifier that will magnify a huge different range, and you've got a much longer working distance, and often the phone itself is much lighter than a standard magnifier. So there are lots of reasons why some people might say, actually, my phone does this better than the optical magnifier. I think it's always important to have a backup magnifier anyway. So I always try and talk people into having at least one, just in case their phone battery dies, or they want something that's like a little shopping magnifier that they can put in their bag. So how do we measure magnification? How do we work it out? So we measure the smallest black and white letter that you can see, and then work out how much smaller the target letter is. So say you want to read newspaper size print, and we would work out the power of the lens that you need to make the letter that you want to see as big as the letters that you can see, if that makes sense. I'm not going to go into all the optics of it here all evening on that, but that's the general way of doing it. So I'm talking here mainly about handheld magnifiers that you would use for reading, but the principle is exactly the same if you want to magnify in the long distance. So there are lots of different types of magnifiers, as I mentioned earlier, but in the distance, we tend to refer to them not as magnifiers, but as monoculars or binoculars or telescopes. And these work in exactly the same way, in that they make the letters. Say you're looking at a train indicator board, we would use a little telescope that will enlarge the letters on the train indicator board to the size of letters that you can see on a standard letter chart. The problem with telescopes, much like a handheld magnifier, is that there's a small area that you can see through. So they can be a bit frustrating, but they're very useful for just a quick spot looking at the train indicator board, or a notice board or something like that. And it's absolutely essential you have some training to use them. And as I mentioned earlier, electronic and optical magnifiers, there's some people will always prefer an electronic magnifier, some people always prefer an optical magnifier. But in a low vision assessment, we should go through all of the different options and work out what's best for you and what's best for the task that you're trying to do. So for some people, an electronic magnifier might be good for, so your mobile phone, your smartphone magnifier might be good for some tasks, and an optical might be good for some other tasks. So there's not one size fits all. And in a good low vision assessment, you should have the opportunity to talk through what will work for you and for the circumstances that you have. So under the category of bigger, there's also enlarging the task itself. So a big print book is an example of making something bigger. Big button telephones, that's also an example of making something bigger. And electronic magnification, say for instance on a computer software that will make your computer screen font bigger. There's a limitation to how big you can make something, because, for instance, in big print books, you can only go to really about 2 times bigger, because otherwise the book becomes very big and very heavy. So although that seems like the most simple way to do it, there's quite a restriction on actually who benefits from making things actually physically bigger. And then we've got the category of brighter. So this is really a long discussion around lighting and the management of light. Task lighting is something that is beneficial to pretty much everyone, even people who struggle with light sensitivity. So task lighting is where you've got a light that goes onto a specific activity. So that might be reading, it might be under cupboard lighting. So on the slide that you'll get, I've got an example of our kitchen area at RNIB, where we've got lighting under the cupboards in the kitchen area that goes straight onto the work surface. So it illuminates the work surface, but it doesn't create general glare or increase in light in the room. And that makes what you're looking at on the work surface much easier to see. We talk about general lighting as well, because what you find is if you've got a problem with your vision, often you think, right, I'll make the room light bigger. But actually making the room light bigger just creates a glare source. So it can be really uncomfortable. It can make your vision worse by doing that. So we talk a lot about general lighting. And generally speaking, for most people, an even light throughout the house means you don't have to change, you don't have to adapt to a brighter light in the kitchen, a duller light in the living room. It's more comfortable on the eyes and more effective generally. But most houses are set up to have bright bathroom lights, bright kitchen lights, and sort of ambient light in the living room. And that's not necessarily ideal for someone with visual impairment. But we talk you through that in the assessment, or we should be. And then the control of daylight and glare. So, talking about having vertical blinds at the windows or net curtains that you can reduce the light when you need to, but you can increase the daylight into the room when you need to as well. We might issue glare shields, so wraparound sunglasses for areas where you can't control the light level. So if you're out on a bright sunny day or in Tesco's with the bright spotlights, a wraparound glare shield might make a big difference. So we talk everyone through that, maybe try some on. The important thing with a glare shield is to try it in the environment that you're getting the symptoms of glare. So we might stand you on the doorstep and see what you think with the different colours. And then bolder. So this comes back to my contrast sensitivity chart. So the chart that gradually fades out. The use of bolder strategies means that we increase contrast. And again, it touches a little bit on brighter as well, because it's also about glare control, reducing glare and dazzle and increasing contrast. So if someone doesn't do very well on that contrast sensitivity chart, sometimes a magnifier actually isn't the right thing. Just talking about the use of contrast can make a huge difference. So black on white or reverse contrast to reduce glare from a white surface is really good. But other examples of that are the yellow lines around the escalator stairs, so you know where the step is on the escalators or on staircases in and around public buildings. Contrasting edges, I mentioned about perhaps putting a purple band around your light switch so you can see where the light switch is. Um, you could use contrasting chopping boards, so chopping a white onion on a black chopping board so you can see the onion against the board. Those sorts of things, little hints and tips, highlighting the edges of cupboards and that sort of thing. Sometimes we prescribe yellow tinted or brown tinted glasses. These are called blue blocking glare shields, but what they do is they enhance contrast as well. So bolder is talking all about contrast. And then the last two strategies I've lumped together in this talk, audio and tactile. So these are otherwise known as very jargony sensory substitution. So in other words, these are for tasks where we think that using an optical magnification or a visual way of enhancing it, like the using lighting and that sort of thing, is not really going to be good enough for you. Then we'll think about using audible things or tactile things. So examples of these are talking books, talking kitchen equipment, so scales and microwaves and thermometers and that sort of thing, braille labels, electronic options that will talk to you, and things like long canes. So long canes is an example of a tactile sensory substitution. So the long cane is feeling what's ahead of you, so that you have a warning before you trip on something, a scooter that's been thrown on the pavement in front of you. So on my slide, I've got some examples of bump-ons. So bump-ons is another tactile example. Bump-ons are little rubberized spots that you can put onto dials on kitchen equipments or on remote controls, that sort of thing. So you can feel the button rather than have to get up close with the magnifier. Lots and lots of people will use a whole combination of all of these. So they might use talking books for reading for pleasure, but they might use a magnifier to read the labels on their cooking instructions and that sort of thing. So we call that spot reading. And reading fluently, so reading a book for pleasure might not be possible with a magnifier, but a talking book would be much more enjoyable. So that, just wanted to say that just so that you know that we're looking at all of the solutions for an individual, and it might not be just the one solution. So who will you see depends on the service. So the low vision practitioners can be optometrists, they can be dispensing opticians, they can be orthoptists, and in some areas, actually, the vision rehabilitation specialist might have undertaken some additional training to do the low vision service as well. So it really varies. Every low vision service is commissioned by their local area. So depending on where you live, you'll see a different person. They should introduce themselves and they should tell you, sort of who they are and what they're going to do. But never feel reluctant to ask. It's always important for you to know who it is you're seeing and what their background profession is. Where is the low vision service? So this again depends on the area that you live. So each area commissions their own service, as I mentioned. So it could be commissioned in the hospital itself. It could be commissioned at the local society for people with visual impairment. It could be in a community setting, such as the opticians locally. So in Wales, for instance, I expect there's not many people here from Wales, but in Wales, that's all in opticians in the high street. In London, where I'm working, our clinic is in the community. It's a little opticians that's commissioned specifically to provide a specialist service. But there are also lots of hospital-based low vision services in urban areas. So in London, predominantly the low vision service is within your hospital. If you are not sure, then the best thing to do is to ask your ECLO, your optician, your GP, or your consultant. All of those people know where the low vision service is. And often people don't get referred into the low vision service at the stage at which they could actually really benefit. So please do ask for referrals. No one's ever going to mind, and it might be that they just haven't realised that no one's referred you already. So I've just moved on to another slide. You'll see that I've listed out all the different ways you can find out your local service. The other one that you can do is you can phone RNIB helpline or use RNIB Sightline directory. And in the slides, there'll be the link to the RNIB Sightline directory. All you do is you put in your postcode or your hospital name and low vision services, and it will tell you where your local low vision service is. So let's just move on to how you get an appointment. So call the service. If you can find the local service, call them and ask how you get an appointment, because every service is different. So for instance, my service at RNIB, anyone can refer themselves. The ECLO refers to us, the GPs, the eye doctors refer to us, optometrists refer to us. We will literally take any referral. And what we do is when the person phones, we'll talk them through what we're going to do and just check that they are suitable for the service so that we don't waste their time getting them in and then they find it actually what they really need is the vision rehabilitation specialist. So it's important that you don't miss out on low vision services. And I think if you, having listened to me and you haven't had a low vision assessment, it doesn't matter if you haven't completed your course of treatment, if you're waiting for operations and things like that. low vision practitioners can see you at any stage. No one should struggle with their vision without the help of a low vision assessment just because they're in the middle of treatment. And we do see people that are referred into low vision or refer themselves into low vision much later than actually we could have helped them. So please do seek some help if you think you've missed out. Um, in every area, there is a set criteria for accessing the service. So there can be sometimes limitations. So having said that, if you've missed out, you should phone them, etc. But your age, so some services won't see children, and so it's important that you know that there may be an age criteria. Your postcode, so they are commissioned by the postcode of your GP practices mostly. So it might be that you might not be eligible for the one you think you are, and they might have to send you to a different one. The level of vision, they shouldn't have a level of vision criteria, but I'm still finding out of low vision services that do have a criteria for the level of vision, and also who can refer. So there are some services that you can't refer yourself into. If that's the case, then you're still eligible to use that service. You just need to find who it is that needs to refer you. So it might be your eye doctor in those cases. So, for instance, at St Thomas's, where I work, all of the referrals have to come from the eye department. So they don't take referrals from external providers. There's lots of reasons for that, and some of them are really good reasons, but it means that you couldn't phone me at St Thomas's and book an appointment. You'd have to go back through the eye department. So I'm just going to finish by saying why you should ask for a low vision assessment. If you have some usable vision, you can get help to make the most of that vision. And it really is a good use of your time to have someone that has a professional background in managing optical lenses and those sorts of things to help you make the most of the vision. You may well be very surprised at what's possible. If you're struggling with glare and dazzle, then we may be able to help you manage the discomfort and actually may even improve the vision with glare control. We can give you advice about certification and registration. And above everything else, and I think this is what most people say, is they have more time and space to talk about the impact of their visual impairment. So it gives them a lot more time to be able to, just express the difficulties that they're having. And then you can learn about other services that might help you too. So a good low vision service should be linked in with the whole network around them. So all those other services that may well be of use to you. So hopefully you've got the message there that if you think that this is for you, then and you haven't had any help on it, then please do reach out and get that help. So there we are. That's all I have for you. And now I'm really happy to take any questions at all.
Thanks, Louise. Thanks for a great informative presentation and telling us how we can maximize and use the remainder of our sight that we have and how to use it effectively with all the different low vision aids that you've talked about. Thank you so much. I'd like to tell everyone before we move over to Q&A, the details of our next webinar. So it will be on Monday, the 14th of October, same time of 7 p.m. And we'll be hearing from Helen from RNIB talking about the public facing pathway, a pathway which will be launching next week. And it gives people, with vision impairment at risk of developing sight loss, parents, and how to use this fantastic resource about getting the right information, getting the right help and support at the time you need it. So it will have hints, tips, prompts, which professionals you should be speaking to, and it's just a fantastic resource. So we'll be hearing more about it and how you can access it. So we'll wait to hear from Helen next month.